Hi everyone, this is Professor Widener. Welcome to the week number 7 and 8 module, module number 4. This module will run over 2 weeks, and that's because there's a lot of information to go over. And the first thing that we need to know before critically appraising quantitative evidence is what quantitative evidence is. So you'll notice some of the supplemental materials focus on that. And then there's also, as this PowerPoint will, and some additional materials focused on critically appraising quantitative evidence to be used for clinical decision making, which is AKA evidence-based practice. So how do we look at a study and decide if it's a good study or not, and then decide if it's worthy of being understood and applied to our patients. So try not to get too overwhelmed. Again, it's more important to understand the process of this than it is to necessarily memorize it. So for the discussion board this week, you'll post your article that you're going to use for the evidence-based practice critical appraisal review for next week. And then once I approve the article, you can start working on your critical appraisal paper. There are no responses required this week, just posting of your paper. So moving along with the PowerPoint, there are 4 phases to critical appraisal of quantitative studies, and that includes a rapid critical appraisal. And the point of that is basically to decide, are these studies worth being further looked at? Once you decide if they are worth looking at, then you will evaluate the studies and extract data from them, which includes the specific information from them. And then you'll look at those. If you have multiple studies to look at, you'll look at the agreed information across all the studies. And then the third phase is to synthesize all that information into one body of evidence and paint a picture of what the body of evidence tells us. And as you move through your program and into the next capstone courses for the MSN students and DNP classes, that's what your goal is going to be to do. We're laying the foundation right now, but your goal is going to take some of these articles that we review and decide if they're good or not, and then pull them to a body of evidence to either make a project or make a recommendation. And that's number 4, where we talk about the next steps for practice, and it's based on the evidence. And they can be clearly articulated. Basically, it means there's no gray area. What the next steps are based on the evidence in these articles. So when we're getting started to do a general appraisal overview, basically what we're going to do is just document, talk about, and think about the study. It provides an overview to get appraisers started thinking about the study to be appraised. This is not a rapid critical appraisal. It's simply a preliminary step, just looking through some articles to decide, is this worth it or is it not? The rapid appraisal includes levels of evidence, detailed questions that are good markers of a quality research design. So when we're doing a general appraisal overview, what we're going to do is why was the study done, or the purpose, what was the study design, and was there an appropriate ethics review or IRB approval prior to the study. Then when we talk about general description of the study, we want to know the question, or what were they trying to solve. Then you want to consider sampling techniques. What was the technique they used, and what was the size? The next things we're going to think about are the major variables that were studied. So when you think about those, you want to decide, was there independent and dependent variables? are the measurements of those variables valid and reliable? And remember, we talked about validity and reliability. How was the data analyzed? Were the statistics appropriate? So take the information that we've learned over the last 2 weeks and decide, when you're looking at that data, do you think the statistics that they used were the right ones to represent the information that they found? Were there any untoward events during the conduction of the study? Sometimes studies have to be finished early because there's negative results, or sometimes they're finished early because they are going so well. So anything that happened during the study, and then how do the results fit with previous research that has been done on this topic, and what does this mean for clinical practice? So question number 1, the statement that best describes GAO is GAO stands for General Appraisal Ordering. GAO and Critical Appraisal are different names for the same thing. GAO is a working form that allows clinicians the opportunity to document their thinking about the study, or appraisers do a GAO after they're done with their critical appraisal. So we're going to remember that this is a preliminary review, so it's going to be C. And this gets you to start thinking about the study and decide if it's something that is worth looking at more in depth. And I'm going to post, there's a specific format to do a critical appraisal, and I'm going to post that information in the paper that you'll be required to write, but that way you'll know specifically what questions I'm looking to answer. So just check that out when you're all done with this. So a rapid critical appraisal of a quantitative study, you're going to look at the study's place in the levels of evidence and hierarchy. So, and we're going to go into all these a little bit more, but are the results of the study valid or validity, and are the results reliable? And will these results actually help me in caring for my patients? And what you're going to think about is, do these results actually help answer my PICO-T question, or give me some backup information for that? The level of evidence hierarchies provides some important guidance, and we'll look at them in the next slide, but there are a variety of different hierarchies of evidence, and some are more important than others. So this is the hierarchy of evidence when we're looking at evidence-based questions or quality improvement. At the bottom, we have expert opinions, and if you're working on something in the recovery room and you've been a recovery room nurse for a while, you could be the expert opinion on your level of evidence, but again, it is the lowest level of evidence, but nonetheless does have some usefulness to it. The next level is case studies or case reports and evidence-based implementation from quality improvement projects. So maybe I'll give you an example. When I was at our hospital, and I think I've said this before, when I worked at Wayne Memorial, we were having a problem with urinary tract infections because Foley catheters were being left in too long. So without any evidence, we added a documentation site to the provider's daily document to double check if patient had a Foley or not, and if they did have a Foley, why. And if they didn't need the Foley, it prompted them to get the Foley removed. So what we found is that just that simple prompt of having people have to document why someone had a catheter decreased infections because it improved Foleys were being removed faster. So again, the point is, we didn't really have a lot of evidence to do that, but we made it a quality improvement project and it worked. So that would be an example of there. And case studies, we've heard actually a lot about case studies over the last year because of COVID-19. When it came out, we didn't have any idea really how to treat it. But again, with case studies, somebody was able to say, well, case studies, again, are more specific to one or two people. They told us, well, we had results with one or two things, and then that prompted further research to be done. So the next two are uncontrolled and controlled cohort studies. Those have a little bit more rigor to them. And then once we start getting to the top, we have non-randomized control studies, and that is where there is we're looking at a specific group, but non-randomized means that they're taking a group of selected individuals, or you're getting a group of individuals that are all part of one area. In randomized control trial, that is one of our highest levels of evidence, and that is where groups have been randomized specifically based on the inclusion and exclusion criteria. And again, that will be one of your one of the things that you need to leave the class with. And then finally, the second kind of article you'll need to leave the class with is a systemic review. And that is basically where someone has looked at a bunch of studies and pulled all the evidence together to make this review. So in this level of intervention, you want to obviously try and have as much evidence, the highest level of evidence that you can. But again, we're in this unique position because of the pandemic. We didn't have a lot of evidence, so we've had to rely on some of the lower levels of evidence as we build the other types. So hopefully that makes sense. But then again, remember, we are going to leave this class with a randomized control trial, a systemic review, and a guideline, and we'll work on all those together over the next few weeks. So validity is whether or not the results of the study were obtained with a sound scientific method, which basically means, can the results of the study be believed? Do they can they be generalized to other types of patient populations? And there are such things as study bias and confounding study results that can impact the validity. So what that means is, like, were there specific things that make you suspicious of whether or not this is a valid study? Based on other things that you know about this, or does it follow other research that has already been done? Study validity refers to whether the study results can be believed or whether the results can be generalized to other settings and populations. And again, that's the whole goal of evidence-based practice and the goal of the DMP projects. We're trying to make something that can be generalized to different settings and patient populations. Instrument validity means, are the instruments actually measuring what they're supposed to be measuring based on the study design? So if something is measuring X, but you really wanted Y, that's going to be invalid because of that. Validity can be determined, and there are several different types of study bias, and I'm going to just give you a brief overview of each of them. Selection bias is where a researcher assigns who will be the participants, that it's not random. Randomized controlled trials are better than non-randomized. Number two, knowledge of who receives the intervention. Sometimes the researcher may know too much information prior to the study, and that can represent a kind of bias. And I'll give you an example. For my PhD project, I wanted to do a study about a rural area. Well, I can't do it on the northeastern Pennsylvania area, like specifically Honesdale, because that's where I live and I know too much information about it. But I could expand it to all of northeastern Pennsylvania, and then I don't know as much about it. Number two is gatekeeping, and that is how information is disseminated. Basically, they decide, like, what results are reported and what results aren't. Measurement bias is when information is collected as a study variable, but it's not actually accurate, or it doesn't exactly explain how you got that measurement. That can also be called information bias. That means it lacks accurate information related to the key study variables. So information and measurement bias are about the same. Recall bias is when, this is particularly like in a case study, when you're asking someone to recall the information about an event, they may only recall certain information about the event based on whatever the outcome was. Number 7 is loss to follow-up, and that means like if you do an initial intervention with someone and then you try to find them for the follow-up to get follow-up data, you can't find them. And that certainly does happen. And then the last one is contamination, which means some people receive the intervention that they were not supposed to. So if you have an intervention group and a non-intervention group, the non-intervention group receives the intervention. So essentially there's no difference between the two groups. So that can be a type of bias as well. Hopefully that makes a little bit of sense. So also related to validity are confounding study results. So confounding variables are those factors that interfere with the relationship between the independent and dependent variables. They're often encountered in lifestyle and health type of articles, and this would be an example. In studying examination of the nurse's intake of caffeine and fasting-related headache, shift work could be a possible confounding variable. So what that means is that whether you work day shift, night shift, or evening shift could be a confounding variable. It could interfere with the relationship between the nurses and the caffeine. The question that does not address study validity is how big is the magnitude of the effect? Were the study results obtained using sound scientific method? Were there any biases that influenced the study results, or were there any confounding factors that influenced the study results? So the answer is A, because magnitude of effect is one question that is not used to determine reliability. It's used to determine reliability of a study, not validity. So again, validity is whether they used sound study methods to obtain the information. Now we're going to move on to talk a little bit about reliability, and that is whether or not the effects of the study have sufficient influence on practice, clinical or statistically, that the results can actually make a difference when clinicians apply them to practice. So basically, does this make sense to use in practice? That's kind of the key questions, the key big question. But some of the other questions include, how do the numbers add up? What is the magnitude of the effect? Well, if something didn't have that good of results, maybe it's not worth putting in the effort to do it. But if there was a study that showed amazing results, maybe that is worth the effort. And how precise was the effect estimated? And what is the strength of the association? So what that means is, how strong is the evidence to point that this will actually happen? So when we talk about study reliability versus instrument reliability, study reliability refers to if we were able to repeat this study under the same circumstances, would the results be the same? So there is increased reliability if I did the study and then my class did the study and got the same results. That improves the reliability of the study. In instrument reliability, that can yield talks to the consistency of the instruments. So like if you're measuring something on a Likert scale, if the Likert scale is here and the other Likert scale is over here, would those results be the same under the same conditions? Some of the key questions that go a little bit further in depth, but do the numbers add up? What is the total N? And then when you talk about the magnitude of the effect is the rate of the occurrence in which the groups have the outcome of interest. Basically, how important is the difference between the group? And then this is where we start thinking about some of our statistical information. How precise was the effect estimated? Was it statistically significant? Was it clinically significant? And what is the confidence interval of that? And this is where we're going to talk about some of the strengths of the association. And you can use some of these different statistical topics to decide the strength of the association. Statistical significance is when the result of the statistical analysis reveals data that are unlikely to have been caused by chance. You'll often hear this represented as the p-value. So statistical significance is when the p-value is greater than 0.05. Statistical significance is influenced by the size of the sample. Clinical significance is defined as study findings that will directly influence clinical practice, whether they are significant or not. And this is not influenced by sample size. The question that best addresses study reliability is, what is the magnitude of the effect? Did the investigator apply the intervention know which groups were assigned? Were the instruments calibrated according to the manufacturer's specific information? Or how many subjects were lost to follow-up and what groups were they in? A, what is the magnitude of the effect? Magnitude of the effect allows for determination of the results in similar patient populations. So basically, are they generalizable? Answers B and D refer to the validity, and answer C refers to reliability. When we talk about applicability, this is the third key question, and it kind of asks, is this appropriate for a specific patient population? We talked a little bit about some of the studies already, but remember, each study is a little bit different. And for this specific assignment due next week, you're going to use a randomized control trial. So when you look at the evaluation and synthesis of the data, the evaluation is an evaluation of the worth. Basically, when you look at the table that has helped you organize the key points from the literature, including the body of evidence, you want to capture data from the literature. So you want to extract data, basically. And you want to ensure that there's no need to search through the volumes of articles for a body of evidence, and you want to establish patterns across studies. So basically, if you're looking at, and I'm going to give you a table to help with this, but if you're looking at a bunch of different studies, although we're only looking at one for our article, but potentially if you were looking at multiple different studies, you would gather key elements from each one in a table form and decide, were they worth it or were they not? It's basically like a summary form that you'll have. And in each column of the evaluation table holds a key piece of information about the article. So I'm going to put that in the module for this week, so you can start to kind of gather some evidence, again, to take with you and work as building the project. These are some of the sample topics that evaluation tools can have. You want to put the citation, that way, again, if you need it, you have it immediately. What was the purpose of the study, the conceptual framework, what was the study design and the method, what were the sampling and the methods, what were the major variables studied and what were the definitions, how were the major variables studied, data analysis and the study's findings, and it's worth the practice. Again, these are all basic information, but just think if you were writing a huge paper and you were looking at like 25 studies, this would help you pull all that information together. So it's just a good way to organize data. And you'll be putting on there just your 3 to 4 articles. And just remember, 3 is kind of the minimum, but if you have more than 3 articles, you can put as many as you want on there to continue to kind of work with as you build your capstone and DMP projects. The last thing you're going to do, and again, this is going to happen as you move into your other capstone and DMP courses, but you're going to put all the information together. Basically, you're going to synthesize it, and that may take on a form of a study, that may take on a form of a project. Basically, you're going to synthesize the information to gather it all together to decide what is the essential interventions that you need and what are the commonalities between all the research that you've looked at. So which of the following statements is true? The main difference between an evaluation table and a synthesis table is that evaluation tables are used to compare and contrast studies that are included in a systematic review. False. An evaluation table simply serves as a way to organize a body of evidence and identify patterns. Synthesis tables pull all the information together. So I know this is a lot of information. If you have any questions, just please let me know.